Alright class, so this is part 2 of the lecture of the first 31 slides. We're going to go through the knee assessment, and as with all the other assessments that we've done, I mean they're all pretty much similar. Just some specifics about each point here, because it's the knee, and then you can also have acute and chronic injuries, and there's always going to be specifics to each joint that you're assessing. So for example, determining the mechanism of injury is critical. So you can either do that by, you're either going to be there when the injury happens, or you have to ask good questions from the athlete and also the teammates of the athlete. They can give you good information as well. The coach can give you a lot of information about what happened. So you want to ask all the relevant things. What position was your body in? Did the knee collapse? Did you hear a pop? Could you move your knee immediately? Was there swelling immediately? And where was the pain located? And the next thing is this an acute injury or a chronic injury? So did it happen during a practice? Was there a specific incident? Or has this been something that's been nagging you for the last week, 2 weeks, and finally it's gotten to the point where it's affecting your performance, or you notice it even when you're not practicing or playing in a game? Is there recurrent swelling? Does the knee lock or does it catch? Is there severe pain, grinding or grating? All these things are going to give you a better idea of the pathology, and you're going to be able to narrow down the pathologies to 2 or 3 things that once you get into the observation part of the assessment, you're going to be looking for specific things, but then also you're going to be looking for abnormalities. And for example, with these pictures that you see here, you're going to notice some things that could put the knee at a very exposed or very high risk position. For example, being in Janus valgum or a knock knee position. That's going to put a lot of stress on the MCL. It's going to put the ACL in a position where it's already being stretched. So those are the type of things that you want to notice as you're assessing the athlete. Another thing is genu recurvatum, which is in this top right picture here. That position is just already putting the athlete in a very disadvantageous position. If that's their normal stance, then anytime they're landing, that they're jumping from a land, or that they're landing from a jump, this is one of the positions that their knee may just automatically go to, and that just puts the ACL, the PCL, the meniscus, and it just puts a lot more stress on those structures. And that's something that if you notice it, then you have to address it. You can't just let it go. You have to try to accommodate for that. So strengthen the quads a little bit more. Make sure that their hamstrings, that their glutes are firing correctly anytime that they're running, jumping, or moving. Alright, so the next portion of the assessment will be palpation. So once you get to the point where you can start putting your hands on the athlete, you want to have a good protocol, and here's a good protocol for that. The athlete should be in a supine or sitting position, and the knee is usually flexed to 90 degrees. But you can start in a full extension position, then move into a flex position, and then you go from bony structures, checking for any deformities and pain, and then you move on to soft tissue. So you go to ligaments, and then you start assessing the joint line, assessing for pain and tenderness. Once you're done with the palpation portion of the assessment, then you would move on to special tests. We're going to get into several of the knee special tests. And the main thing that you're looking for is instability, because anytime you damage one or several of the ligaments of the knee, one of the main things that they're going to feel is instability. And you have to assess that instability, and you have to compare it to what their normal leg feels like. So classification of joint instability, that means like the knee laxity includes both straight and rotary instability. And translation will refer to the glide of the tibial plateau relative to the femur, and that's going to test the ACL and PCL. That relates more to those two ligaments. And then it says, the third bullet point says, as damage to stabilization structures increases, laxity and translation also increases. So, in short, it just means the more ligaments or the more structures you've damaged, then the more laxity you're going to feel compared to what normal is for them. The valgus and varus stress tests, as we'll see, are used to assess the MCL and the LCL. And then the last bullet point there tells you that you can test it at 0 degrees or 30 degrees of flexion. And one tells you a little bit more about the joint capsule, and then flexing a little bit more isolates just the MCL and the LCL. Okay, so the first special test of the knee that we're going to look at is the valgus stress test. And as stated before, it's going to test the MCL. So as you can see here, the examiner is standing lateral to the patient, and they're stabilizing at the tibia, and then they're mobilizing at the joint line, at the lateral joint line, and they're giving a valgus force because it's going from lateral to medial. And as stated before, in full extension, you're testing the MCL, but you're also testing the joint capsule, the integrity of the joint capsule. Here you're at 30 degrees of flexion, so slightly bent knee, and here you're isolating strictly the MCL. So aside from just checking laxity and straight position, you also want to test it at 30 degrees of flexion. And the first will give you information about two things, the joint capsule and the MCL, whereas this one is strictly to find out how much damage to the MCL you have. The next special test is a varus stress test, so that's varus with an R. And you got to make sure you guys are familiar with those two terms, valgus and varus. Varus stress test tests the LCL, so the lateral collateral ligament. And here, again, you're stabilizing the tibia, but now you're pushing from inside to outside of the knee, and that would be a varus stress, and it would force, or it would try to open up the knee laterally. So if the LCL is intact, then you'll get a good end feel. If it's not intact, then you will get a lot more opening. The end feel will not be as firm compared to the uninvolved side. The next test is the anterior drawer test. Here you have the patient with the knee bent. Well, first they're supine, so they're laying on their back. The knee is bent to about 45 degrees of flexion. The examiner is putting their thigh over their foot to stabilize the whole tibia, and then they have both of their hands grasping from the posterior knee, and then they're giving an anterior force, so they're pulling the tibia anteriorly. The femur is being stabilized by the weight of the patient. So that pretty much leaves only the ACL, the hamstring tendons to prevent the tibia from completely moving away from the femur. So as you test this, everyone's going to have a certain degree of laxity here, and that's why it's so important to test bilaterally, because you have to know what is normal for one person and what is normal for another, because this may open up a lot for one person and you may think, okay, the ACL is gone, but if you test the other knee, you may get the same degree of movement or translation. And here you'll be able to feel, the more times you do this, you'll get a better feel of how much movement there is. The next test is also testing the integrity of the ACL, and in this test, the knee is tested in more of a straight leg position, and one hand is stabilizing just above the knee, so grabbing the thigh, and then the other hand is grasping right over the tibial tuberosity and applying an anterior force. And again, we're just checking for laxity and to see how much translation we get compared to the other knee. The posterior drawer test looks exactly like the anterior drawer test, except that now you are giving a posterior force, so you're pushing backwards. If you go back and look at the slides describing the the movements that each of these ligaments prevents, the PCL would prevent posterior movement of the tibia in relation to the femur. So we're testing the integrity in that motion. And again, you have to test this bilaterally to make sure that you're not getting a false positive. Here is a meniscus and also MCL, LCL tests, Apley's compression and distraction tests. Here you have the examiner with their hand in the popliteal space, so behind their knee, stabilizing, and then the other hand is at the heel of the foot, and they're giving a axial load, so pushing straight down, and then also a twisting motion. This would cause a lot of pain in whatever side or what meniscus the patient would have a lesion in. And if they complain of pain with that, then the second step to the test is to apply distraction. So distracting the knee, pulling upward, that will cause relief of that pain. Here we have apprehension test, and this is a test similar to the apprehension test in the shoulder, in that you're basically looking for the patient to feel or to demonstrate apprehension as you're moving the patella. So here you're providing a glide, a lateral glide of the patella, and if the patient describes a feeling of that the patella is going to dislocate, that you would feel a lot of laxity there compared to the other side, then that would give you a positive. So some additional things that you can measure, that you can examine, are girth measurements, functional exercises, patellar examinations, Q angle, leg length discrepancies, gait analysis, and posture analysis. And all these things are just going to give you some further detail about what's going on with the athlete and what could be causing the pathology that you're dealing with. Because you definitely want to treat the symptoms of what the patient is going through, but you also want to get to the root of the problem. And if you can start treating that, the better success you're going to have with the rehab, and then also you're going to have more success in preventing injuries, or at least lowering the risk of that injury. So, for rehab purposes, girth measurements, functional exercises, those are things that you can measure, pre-season or pre-rehab, and then measure them, either weekly or monthly, and then towards the end of their rehab, as they're returning to play, to see where they're at, and that will give you a better gauge of how functional, how much gains they've achieved. One of the last things that can be done is also leg length discrepancy measures, and there's a specific way to do this. And here you see the examiner measuring from the ASIS to the medial malleolus on each leg, and you also measure from the umbilicus to the medial to the medial side of the foot to determine whether this is a functional leg length discrepancy or if it's an anatomical leg length discrepancy. One you can fix by doing muscle energy and realigning the hips. The other, it's just genetic, and the only way to really fix it is by putting a heel lift or doing something with their shoe. So just some things to remember, and that is the end of the lecture there. If you have any questions, please let me know.